the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine and is the co-director of the Tourette Syndrome Center of Excellence. His research seeks to improve the identification, assessment, and treatment of children, adolescents, and adults with Tourette syndrome and other tic disorders. Dr. McGuire has received numerous national and international awards. He has co-edited 3 books with Elsevier, published over 150 peer-reviewed journal articles and book chapters, and has given dozens of conferences presentations. Dr. McGuire's research has been supported by the National Institute of Health, Tourette Association of America, American Psychological Foundation, Hilda and Preston Davis Foundation, Misophonia Research Fund, and the American Academy of Neurology. We are very grateful to have you here today, Dr. McGuire. Thank you so much for sharing your expertise with us during this session, and I will hand it over to you.
I really appreciate the warm welcome. I think the thing that wasn't in the introduction is my mom also thinks I'm really great too. Which I think is possibly the most important part. But I'm teasing. So I'm Dr. McGuire. I'm really delighted to share with you guys a little bit of information today about tics. And let me see if I can share my screen, because despite my knowledge of tics, I am technologically success. Wonderful. So practical considerations for identifying tics in primary care. Some disclosures. I serve as a consultant for MLX Biosciences and Noema Pharma. Basically, they're running clinical trials to test new treatments for individuals with Tourette syndrome and ask me to provide feedback on their assessment practices. But really not talking about any of the medicines today that they are investigating. So objectives. By the end of this presentation, it's my hope that you'll be able to recognize and identify tics in your pediatric patients, describe brief rating scales that are available to assess for tics, and really come away from this presentation understanding evidence-based treatments for tics in pediatric patients. So if by the end of that, if I am successful, you'll be able to do that. If not, I failed epically and give me negative ratings. Okay, just a little bit of background about tics. And Tourette syndrome. Tics are relatively common, and this was something that I didn't really know a whole lot about when I first got into the field. We know tics typically onset in childhood, but in studies put out by Roger Curlin and even replicated by the CDC, actually about 20% of children will have tics at least for some period of time in their life. This might be a period of 6 months. And then tics kind of naturally start to kind of go away. So they're a normal part of development. As you can see here, George Gila de la Tourette over here on our right is exhibiting several common motor tics that are there. And initially the slide had some vocal tics, but then it got too distracting, so we took those out. When we actually think about, so we know tics are common. We know tics affect a lot of children. When we actually think about how prevalent kind of a diagnosis of Tourette syndrome or Tourette's disorder is, it really only affects about 1% to 2% of the population. So not nearly as much as we might think. And the prevalence studies vary a little bit between Europe and the United States, with the United States being about 1%, and Europe or places with more nationalized healthcare having slightly higher rates due to better detection. What goes into that tic disorder diagnostic criteria, or rather, what do those 1% to 2% of children actually what does it mean to have that kind of persistent tic disorder or Tourette's disorder? When you only have motor tics, that lasts longer than a year. So as opposed to just having them for a few months, these tics stick around longer than a year. We call it a persistent motor tic disorder. When you only have vocal tics, which is less common, it's mainly more motor that are identified, we call it a persistent vocal tic disorder. When you have both motor tics and vocal tics, or at least one vocal tic, what should we call it? The answer that I often get is persistent motor and vocal tic disorder, right? Unfortunately, our good friend over here, George Gila de la Tourette, kind of associated his name with it, and we actually call it now Tourette's disorder, or back in the day, Tourette's syndrome. So really, it's not. There's a bit of this misperception that it's a more severe form of the condition, but it just really means that you have both kind of motor tics and vocal tics that have stuck around longer than a year. When we think about how tics kind of develop, what you end up seeing is that ticks develop in this rostral caudal fashion. So it starts in the kind of face, moves back and goes down towards the body. So you might even kind of start to notice at first, with the first onset of ticks starting to develop in the eyes and the face. What are common tick types? Well, for motor tics or those motor movements, really the first and most common ones are eye blinking or eye movements. This might be eye rolling, eye darting. You may see face movements like a facial grimace or smiling or pressing lips together. Other common motor tics that tend to start in pediatric patients tend to be head movements to the side, or even little kind of shoulder movements or shoulder shrugs, just like that. So really nothing too minor, and they start to we'll talk about the clinical course of kind of tics in a second. In terms of the most common vocal tics, really sniffing and snorting. So sniffing goes in, snorting goes out. Throat clearing like that, grunting, coughing. These are a lot of things that people may kind of start to even come into the doctor's office during the winter time, where, oh, I have a sniff or a sneeze or throat clearing or coughing that doesn't seem to kind of fully go away. Other common vocal tics include animal noises. This might be squealing or barking, or even atypical breathing patterns. This may be something like, so kind of quick patterns of breathing that are there and then go away. One kind of point that I'd like to kind of highlight is the frequency or kind of commonness of corporate phenomenon. And corporate phenomenon are kind of the tic that involves making an obscene gesture, which is corporapraxia, or corporalalia, which is saying obscene words to people. Despite the common perception that people with tics and tic disorders have corporalalia and corporapraxia, really it actually only affects about 10% of individuals with TS. While we think about tics as kind of motor and vocal tics as kind of the tip of the iceberg and the thing that people really kind of are most visible, it's important to note that over 80% of individuals with Tourette syndrome have at least one co-occurring mental health or neuropsychiatric condition. These conditions often include inattention, hyperactivity, and impulsivity, or what we think of as kind of those symptoms of ADHD, obsessive compulsive symptoms, as well as fear and anxiety. So things like obsessive compulsive disorder, or even kind of any sort of anxiety disorder relating to separation, social, or generalized are probably the most common ones. Individuals with Tourette syndrome often also experience irritability and frustration, and may kind of have some moments where they act out or have some disruptive or non-compliant behaviors. They also, about 10 to 15% of individuals with tics also have suicidal thoughts and behaviors. So while the kind of tics are the things that we actually see, probably most prominently, and the things that parents often tend to be most worried about, really it's just the tip of the iceberg, and you see all these other challenges that are beneath the surface. Speaking of challenges beneath the surface, individuals with tics often report experiencing premonitory urges and other sensory phenomena. And premonitory urges are these uncomfortable sensations that are present in the body and build up and ultimately result in our relief. So build up in the body and then are relieved by the expression of the tic. So the best example that anybody ever kind of gave to me is this adorable little 6-year-old kid who came into my office, and he had a faux hawk and was super cool. And he had a throat clearing tic. And what he described to me is that every time he had an itchy in his throat, he did his fluffy, which was his throat clearing tic, and it took the itchy away. And I think that that really is a nice way to kind of think about, what premonitory urges are. These are these uncomfortable sensations, kind of like that buildup of a sneeze. You kind of feel it, feel it, feel it, and then you sneeze, and it takes away that uncomfortable sensation. So in a lot of ways, when we think about tics, they're actually, in some ways, serving a purpose in the moments where there are those premonitory urges. In addition to premonitory urges or those uncomfortable sensations in the body, individuals also have a lot of sensory sensitivities. These might be kind of ridges on socks, shirt collars, fabric sensitivities as well. So again, other stuff beneath the surface of that iceberg. As you might imagine, if you're having motor and vocal tics, co-occurring challenges like we just described, and premonitory urges, this can get in the way both at school, at home, and with friends, resulting either in academic, social, or even educational impairment, and really diminished quality of life, which is what you kind of see in many cases. So what happens to these young people who have tics? Well, we know tics typically onset in between 4 and 8 years of age, so really those kind of early childhood years. We know they reach their greatest severity in terms of kind of number of tics, frequency, and intensity during early adolescence. So anywhere from kind of 10 to 15 years of age, depending on the development. After that, we have kind of three general courses in the absence of intervention. We'll talk about intervention a little bit later in this presentation. The first course is that kind of tics tend to drop down to really minimal levels, and functionally for a lot of patients tend to just kind of go away as they don't cause interference and they're not really prevalent. So that's about a third of kind of cases. The other third, tics tend to drop down and tend to be pretty mild in severity in late adolescence and early adulthood, really aren't causing much interference, but are still kind of present, and during periods of stress tend to be a little bit more noticeable to individuals as well as others. And the remaining third of individuals, the tics tend to be, moderate in severity or greater, and still cause a fair amount of functional impairment and distress to individuals with tics. Then the last question that everybody always asks after that is, well, how do I know, whether my patient is going to fall into one of those three outcomes? And regrettably, we don't know at this time. There's not great amounts of data kind of following people from childhood on into adulthood with Tourette syndrome, particularly now that we have some evidence-based interventions. So we really need to do a little bit more research in that area. So hopefully in a couple of years, or with some research collaborations, we'll be able to answer those kind of really important questions soon. Okay, so now everybody knows a little bit more about tics and tic disorders. Let's talk a little bit about how to kind of assess for them. Unfortunately, we don't have a standard kind of litmus test or a blood test for Tourette syndrome. Really, it's a clinical or a diagnostic interview based on symptom presentation. So asking the questions, does the individual have motor tics or motor movements only, vocalizations only, or are they having kind of both motor and vocalizations? If they're having both motor and vocalizations, have those motor and vocalizations or any sort of symptoms been around for a year or less, which really starts to determine whether something is a transient tic disorder diagnosis or meeting that kind of diagnostic criteria for that persistent tic disorder or Tourette's disorder diagnosis. Did the tics start prior to 18 years of age? Is Tourette syndrome or Tourette's disorder is a neurodevelopmental disorder? Really, that's one of the kind of diagnostic criteria for it. And also in that diagnostic, ruling out other conditions. I often have this conversation with colleagues who work with patients with OCD as well as autism. And we have to kind of always have that kind of agreement that one symptom does not a diagnosis make. So because somebody is aligning something up or engaging in some tapping behavior, it may not be a tic, but it may be more characteristic of a tic-related compulsive behavior associated with OCD. Or if somebody's rocking back and forth and they also have a diagnosis of autism, that may not necessarily be a rocking back and forth tic. So really being parsimonious in our kind of assessment of symptoms before making a diagnosis. What are the tools that we use to make diagnoses as well as kind of characterize symptoms and severity? Really, the gold standard is the Yale Global Tic Severity Scale, which is a clinician-rated assessment. It kind of consists of three core parts. The first is a symptom checklist, which runs through, I think, the 62 most common motor and vocal tics that individuals with tic disorders experience. It's not an exhaustive list because pretty much anything can be a tic. But what it does is it helps to kind of provide the clinician who's evaluating the individual with tics a sense of what are the most common tics that are present and that this person might be experiencing. It also assesses the severity of tics based on the number, frequency, intensity, complexity, and interference, as well as rates overall impairment from the clinician perspective. There's also a few self-reported parent rating scales. These are the parent tick questionnaire or the adolescent or adult tick questionnaire. These are kind of questionnaires that are completed by parents and or adolescents or young adults. And they consist of about 14 motor tics and 13 vocal tics, in which you rate the presence, frequency, and intensity of those tics in the past month. And these are both kind of great rating scales, but they also rely on parents and kind of young people being aware of when they're exhibiting tic symptoms. And some patients have a great insight into these things, but other times it's really hard to have that insight, or parents aren't always around kids, so they may not necessarily know how often or how intense these tics are. So really, not as good as those clinician rated assessments. However, when you're trying to kind of see or assess in primary care, these may not be the most sensitive because a patient or a parent may be like, I don't know. I don't know what these tics are. I don't have any of these things. So really, we need to think about more broad kind of rating scales. So there have been a few brief screening tools for tics and TS that have been developed, and I'll just kind of run through them really quickly, and we'll talk about the pros and the cons. There is the motor and vocal inventory for tics, or the Move It scale. The description of tic symptoms, or the DOTS, and the motor tic obsessions, compulsions, and vocal tic evaluation scale, or the MOVES. Which, as you can see, clearly what people do is a good acronym and then try to fit the words on into it. On all of these kinds, these are brief screening tools that all can be completed in about 5 to 8 minutes while somebody's in a waiting room, really to assess the presence of kind of tics and related symptoms like OCD, as you see down for the moves. These things tend to be pretty good at detecting the presence of symptoms, but in truth, it is kind of put together, as the sensitivity analyses reveal, these aren't the greatest tools for actually making diagnoses. So if somebody's having tics, you're going to get a little bit higher positive rate than you might kind of get otherwise. And really, that's where, if you do kind of choose to use these tools in your clinical practice or administer them to a patient, they're more likely going to kind of catch symptoms that are there, but it may not necessarily separate out, whether that is an eye blink due to a tic or an eye blink due to, some sort of compulsive behavior or something else. And that's really where it's important to kind of, once somebody scores positive on these scales, make referrals, to a specialist who can kind of sort all those things out. So in short, these are great ways to identify folks, but really not entirely as good as an expert clinical diagnosis. So we know a little bit about tics. So we know how to assess tics, and once tics are identified, make recommendations to an expert, a TS expert, or TS Center of Excellence. But what goes on into kind of treatment afterwards, and what happens to the kind of patients you refer? Well, practice guidelines have been pretty consistent across the board by Europe, the American Academy of Child and Adolescent Psychiatry, the Canadian Academy of Child and Adolescent Psychiatry, as well as the American Academy of Neurology, and there's 2 forthcoming guidelines that are being put out by the Korean Association of Psychiatry and the Japanese Association as well. And they all pretty much say the same thing. First and foremost, conduct an evidence-based assessment of tics. There's a lot of things that could manifest as tics. So really making sure we're identifying, this appropriately before we start interventions. For interventions, really thinking about psychoeducation or psychological education about the condition. We'll talk about what goes into that for tics that are mild in severity. When tics are moderate in severity or starting to cause interference, really the front line or first line recommended intervention is behavior therapy, which we'll also talk about. And then when tics are severe, pharmacotherapy in combination with behavior therapy is recommended. So what goes on into these evidence-based treatments is, I'm sure many patients and families have a lot of questions about this. So psychoeducation about Tourette syndrome and tic disorders really falls into a few things. First and foremost, providing information to patients and families about the etiology of tics and tic disorders, highlighting factors that contribute to causing tics, as well as identifying factors that do not cause tics. I know there was one family who I saw who was deeply concerned that it was something that they did or something that was, that their fault for causing tics. Not necessarily so. We know the cause of tics is multifactorial. There's some genetic contributions, but it's not a one-to-one relationship. There's some environmental and other factors that kind of contribute to the emergence of tics, but there is nothing set in stone yet. In terms of after providing information about the etiology and what we know kind of contributes to the onset of tics as well as what we don't, providing information about the clinical course, letting patients know that comorbidity is kind of common, and when to expect tics to become much more severe, and what kind of those long-term outcomes that we know about in the absence of intervention. In terms of providing information about evidence-based treatment, really this kind of this focuses on when to intervene and what interventions should be used based on the severity of kind of the person presenting. When is important because if tics are pretty mild in severity and aren't causing an impairment, maybe the kind of best intervention is really just kind of wait and see where things go. Oftentimes, if we try to intervene too early, then therapy for the behavioral side can be considered as a failure because the kid's not motivated and the parents are trying to just kind of be, get their kid into care before tics get bad. Similarly, some parents may want to kind of start a medication pretty early on because they're worried about the long-term outcomes, and really helping kind of parents and families think through, what to treat, what level of intervention is appropriate based on the symptom severity, and when to initiate those interventions. When we think about behavior therapy for TS, and this is those recommendations for moderate severity or greater, really there's kind of two broad kind of behavioral interventions in the United States. The first one being habit reversal training. And habit reversal training was first identified as being somewhat useful for tics back in the 1970s. And it was tested out, I think, for like 22 conditions by Nate Azarin back in the 1970s. And found that it was actually helpful for some of these, as well as kind of hair pulling, nail biting, and skin picking. Habit reversal training really focuses on those internal antecedents or those premonitory urges and related sensations in the body. And first it says provide psychoeducation about the kind of model, saying when you have these uncomfortable sensations in your body and you engage in the tic or the expression of the tic, it serves to kind of unintentionally relieve that expression. The expression of the tic serves to unintentionally relieve or reinforce, the tic behaviors. So what we want to try to do is first and foremost build awareness around when we're having tics, because not everybody is always aware of when they're exhibiting a tic. And then if we can even start to move that awareness further in the process, focusing on those premonitory urges. Once we're first aware of those premonitory urges and or early tic movements, we can start to implement competing responses. As I often tell my patients, you can't stop something or inhibit it unless you're first aware of it. Competing responses are just behaviors that are physically incompatible with the tic. So they're meant to kind of stop the tic, not cause any sort of unnecessary attention, and don't result in any sort of pain. So for example, if I have an arm jerk tic like this, I might first practice with my behavior therapist, building awareness around when I'm doing that tic. And then once I start to feel that urge in my shoulder to do my arm jerk tic, implement a physically incompatible competing response like crossing my arms, so that when I feel that urge to do the tic, I'm not doing it. And in doing so, start to kind of acclimate or habituate to that uncomfortable premonitory urge in my body, which eventually starts to diminish over time. Fantastic. However, that only focuses on the internal antecedents. We also know from research that other factors in the environment can also influence the expression of tics. For example, when kids sit down to do their homework or different social situations or stress and anxiety, they can also affect the expression of tics. So really, you need a comprehensive behavioral intervention for tics, or CBIT, which we'll talk about the evidence for in a second. And CBIT takes those core components of habit reversal training and adds in two additional therapeutic strategies. First and foremost is relaxation training. As we know, stress and anxiety make tics worse, as well as repetitive muscle movements from tics. Relaxation training skills can help reduce stress, alleviate anxiety, and also try to help kind of unwind those muscles that tend to get very tense over time through repeated tic movements. In addition to kind of relaxation training, CBIT also utilizes function-based assessments and interventions. So what's a function-based assessment or intervention? Take, for instance, that example of a child who goes to sit down to do his homework and starts to have a lot of tics. If we think about that kind of reinforcement model, if I sit down to do my homework, have a bunch of tics, and then mom or dad or caregiver lets me kind of not do my homework, that serves to unintentionally reinforce the expression of tics later when I sit down to do homework. What you do in a function-based assessment with an intervention is then start to identify those situations and tackle them in a stepwise manner. So for example, if I'm sitting down with to do my homework and I start to have a whole bunch of tics, I might start to kind of practice my competing responses for increasing amounts of time so that it doesn't interfere with my homework. So I'm still getting the work done, but it might just take a little bit longer. And that's what we really mean by kind of doing these function-based assessments with interventions. Great, what are the outcomes from behavior therapy? And then we'll talk about pharmacotherapy. Really, you actually see pretty large therapeutic effects. So when we do meta-analyses of randomized clinical trials of behavior therapy, if you think about kind of effect sizes, 0.3 is small, 0.6 is medium, 0.8 is large. You're actually getting pretty, large effect sizes and therapeutic benefits. So really, reductions in tic severity are pretty sizable from behavior therapy. Treatment response rates, meaning clinically meaningful improvement, are a little bit more variable. In adults, it drops down to about 40%. In kids, it's a little bit over half. Meaning that when you put these two things together, the take home is for the people who get a lot better, they really get better. But those who don't may not necessarily be responders. One thing that I always like to kind of highlight to patients and families is there's actually evidence to suggest that behavior therapy can lead to the remission of individual tic symptoms. So if there's some particularly bothersome tics that are causing distress and interference, using these strategies can actually lead to their ultimate remission, which I think instills a lot of hope and is really useful to know. What are the factors that influence therapeutic outcomes? There's really three big ones that are known to date. First and foremost, co-occurring ADHD. So for kids who have unmedicated or unmanaged inattention, hyperactivity, and impulsivity, sitting down for therapy and practicing skills can be particularly hard. So if somebody has inattention, hyperactivity, or impulsivity that isn't well managed, it doesn't mean they're not going to get better with behavior therapy, but it may take longer, and or those gains that are kind of relative to other individuals who don't have that may not be as robust in the short term. There's also some evidence that tic medication can influence or attenuate behavior therapy outcomes. Now, that doesn't mean that we don't kind of use tic medication alongside behavior therapy for those kind of severe cases. It just means that there may be some unanticipated kind of consequences or interactions. In particular, what one study by Suhodolsky and colleagues found is that individuals who were on an alpha agonist did not benefit as much from behavior therapy as kind of individuals who weren't taking an alpha agonist. So this could kind of be related to that co-occurring ADHD. While alpha agonists are used to reduce tic severity, they're also used as a non-stimulant medication to manage ADHD symptoms. So there could also be a relationship there as well, which is one of the reasons we need additional research. Last but not least, and this is one of those aha science moments, homework adherence actually matters. What that means is the more you practice your behavior therapy skills, the better you get. So if you're more likely to practice behavior therapy skills and have greater homework adherence or homework compliance, you're actually more likely to be a treatment responder in behavior therapy. And why does that matter? Well, we actually did a follow-up study to some of those long-term, those randomized clinical trials of using CBIT in childhood, and we followed patients up 11 years later. And what we found was something that was really kind of somewhat surprising. Whether you got CBIT or didn't get CBIT really didn't matter. It actually mattered more if you were a CBIT responder. And if you were a CBIT responder, meaning you got the behavior therapy and you used your skills and you practiced them, you got better and you stayed better for up to 11 years later, which is pretty remarkable, especially when you think about what the dose or what the intervention of treatment was. The CBIT intervention back in the initial randomized clinical trial was only about 10 hours of therapy. What do you do for 10 hours in childhood that affects the next 10 to 11 years of your life? And really, it's this, which is quite remarkable. In terms of pharmacotherapy interventions, really we have two classes of medications, antipsychotic medications as well as alpha agonist medications. The FDA approved antipsychotic medications for tic disorders are haloperidol, pimozide, and aripiprazole. Ones that are often used off-label are also risperidone and ziprasidone in randomized clinical trials. Alpha agonist medications tend to be guanfacine and clonidine for the reduction of tic severity. When we look at the therapeutic effects in those same types of kind of randomized controlled trial meta-analyses, we see pretty diminished therapeutic effects for alpha agonists. However, when you actually look at alpha agonists for individuals who have tics and ADHD, you actually see moderate effect sizes, so about 0.6. But if it's only patients with TS, it actually drops down to about 0.15. So pretty minimal effects of alpha agonists in randomized clinical trials if there's only tics, but if there's tics and ADHD, there's some kind of benefit. So really thinking a little bit more about, an estimate of about 0.31 to 0.43. So really ADHD status matters when you're thinking about alpha agonists. In terms of antipsychotic medications, in general, most of them produce about a 0.58 effect size in randomized clinical trials with no one antipsychotic medication demonstrating superiority at this time. So we've reviewed kind of what the phenomenology of tics are. We talked a little bit about assessing them and reviewed current evidence-based treatments. So where do we go from here? First and foremost, if you can't kind of take this away, tics onset in childhood, they're pretty prevalent, affecting about 20% of young people, but don't necessarily stick around in all young people beyond a year. When they do, it affects about 1% to 2% of the population. Evidence-based interventions can positively alter the trajectory of tics. So going back to those initial behaviors, that initial kind of information about the clinical course, we talk about a third, or patients who have tics go away, patients who have pretty mild tics, and patients who have moderate tics or greater. That's all evidence-based interventions. For those individuals who get behavior therapy and actually use the skills, they get better and stay better, even into young adulthood. So really, primary care providers like yourselves play a pivotal role in the early identification of tics. If we're able to identify young people sooner, we can provide appropriate education so that patients can kind of get connected to services and start to learn those behavioral skills at an appropriate time to really alter the clinical course across the lifespan. So at the end of the day, this is really a collaborative effort between providers and clinical researchers. What we're hoping to do, with this presentation, as well as with other presentations and other kind of surveys and initiatives, is really start to listen and learn from primary care providers and receive feedback. Receive feedback on what you guys are seeing and think about how we can kind of develop clinical tools to make kind of, assessments easier, referral processes easier, and anything we can do to start to create a pipeline to get these young people into care. Because early interventions can actually really help a lot of young people and alter the course of illness trajectory across the lifespan. I know everybody is always as interested to learn as much about tics as I know, so we provided some helpful resources here from the CDC, the Tourette Association, as well as the Johns Hopkins and Kennedy Krieger Tourette Syndrome Center of Excellence. I've also provided some references here and happy to kind of answer any sort of questions, comments, and or personal feelings you might have. So thank you. Stop sharing or keep sharing, Molly?
You can stop sharing. Yeah. Thank you so much for that wonderful presentation, Dr. McGuire. So now we're going to move into the Q&A portion of the session. So please feel free to place any of your questions in the chat or also the Q&A function. I saw earlier somebody had their hand raised. I think it was Matthew Wagner. I'm going to allow you to speak if you have a question. Go ahead and ask.
Comment or personal feeling?
Okay, we've got so many hand raised. I'm going to allow you to speak. Let me know if that works for you.
Hi, Diana. I think you're able, your hand is raised. Let's give it a shot and see if you can unmute and feel free to talk. Or if the audio function isn't working, feel free to drop the question into the chat and we will, there we go.
Can you hear us? We see you unmuted, but we can't hear you. All right, we'll try again. Oh, okay.
Hand was raised by accident.
Okay. Okay, Debbie, you can speak.
Okay, thank you. Thank you for your presentation. I just had a question about, we see a lot more, I'm in pediatric neurology. So I've been seeing a fair amount of tics, and I was very interested in this presentation, in particular for some of the high functioning autism and ADHD combination. Do we have any research to say that sometimes there's more tics in the ADHD autism combo, or is it just, we're just seeing a lot more ADHD and autism kind of combined, where sometimes we just see more tics for them compared to an average ADHD kid? I've just, been seeing it, but I don't know if that's just, specifically more neurology. We tend to see the more complex kids, or if we're just seeing more high functioning autism. Just curious as to whether or not there's any research to support that, or if that's still just something we're figuring out.
So Debbie, first of all, one, thank you for attending, and two, thank you for seeing those complex cases. There is some research to show that there is a higher incidence of kind of tics and tic disorders among individuals with autism. There is also research to show that there is a higher incidence of tics amongst individuals with ADHD relative to the general population. So I think what you're kind of identifying is there's a bit of a Venn diagram there. Then when you have both of these things, people with that kind of comorbidity are more likely to have tics. So I think you're spot on. I also think, there's a lot of sensory sensitivities going on in those young people. So, they may kind of have some movements that, may start off as kind of typical movements, but could unintentionally start to become reinforced due to those itchies, if you will, and fluffies, and kind of lead to the development of some kind of tics. I think the cool part is there, even, as a psychologist, behavior therapy still kind of helps. So if somebody has both autism, behavior therapy isn't the most complex thing. We're not talking about feelings. We're really starting to just catch premonitory urges or even early tic movements. So it's really kind of basic. So for young people who may have autism or even have a learning disability, we can still kind of start to the treatment's not overly cognitive. It's very behavioral. So they can still learn to implement it. In a way that's kind of useful to them. And I think kind of making the intervention as simple as possible is just awesome, because then we're able to kind of get people to use the skills. I think the hardest part is kind of catching the tics, and two, remembering to practice, because the more you practice, like that one kind of graph showed, the better you get, and the better you get in childhood, the better that kind of ultimately leads to better long-term outcomes. But thank you for doing what you're doing, and great insights.
Okay, great. Thank you so much.
Okay, we have a couple questions in the chat. So one is, any list of providers who do behavioral therapy? I know you're a co-director of the Tourette Syndrome Center of Excellence at Kennedy Krieger, and we will be sending out a list of resources that has a link to their website where you can request an appointment. But any's off the top of your head that you can think?
So we do it here, when in doubt, if a patient lives. So one, even if they're in nearby states, we have reciprocal telehealth agreements with states through an interstate agreement called SIPAC, which allows us to kind of practice telepsychology. So we're able to kind of do that to increase access to care. One of the other things we're also looking into is so part one, us. If they're really far outside the state or you're doing a consultation, the Tourette Association of America, so TAA, Tourette.org, which is one of the other websites that was on the presentation, has a list of providers who've been trained in CBIT, the Comprehensive Behavioral Intervention for Tics. So patients can kind of peruse that and find people who accept their insurance and go from there. Last but not least, one of my to-dos is to do a research study where we actually kind of take a direct to parent approach of teaching parents and kids how to do behavior therapy through a series of recorded presentations, mainly myself trying to sound really smart and smug, and being silly here, but kind of breaking it down into simple ways to kind of practice and integrate it, because there's a shortage of providers, which is why, in truth, I'm super excited that all of you guys are on this call, because we need more providers kind of doing this work.
Okay. Next question is, I've worked with several young people with ADHD who have tics emerge after beginning to take stimulant medication. What recommendations do you have for these cases in terms of balancing the benefits of stimulant medications versus tics that are exacerbated by it?
So really, really great question. I want to just kind of clarify, I'm a psychologist, not a psychiatrist. But so I can kind of comment on this, but really based on the evidence. This is a common concern and gets asked whenever I do these presentations, both at national and international meetings. And I think the best evidence comes from a colleague of mine, Michael Block, who's up at Yale's Child Study Center. And he did a meta-analysis looking at the incidence of tics following stimulant medications. And there's no greater incidence of tics emerging in individuals with ADHD, greater incidence of tics emerging in individuals with ADHD who are taking a stimulant relative to placebo in clinical trials. So are stimulants are they causing tics? There's no evidence above and beyond placebo. And what he always says after providing that fact is, if somebody is sensitive, he does have many patients who are sensitive to stimulant medications. If a patient is sensitive to stimulant medications, kind of starting to go back down, and you'll start to see the kind of tics diminish. However, what often happens is when tics we know tics wax and wane over a period of 4 to 6 weeks. That's just a natural kind of ebb and flow of the condition. When tics get really bad, or there's a moment where patients are able to get in, there can be moments where we start a medication and tics, just due to the natural waxing and waning course, start to kind of get a little bit more worse, or we start them right before a big series of exams, and tics start to kind of get greater due to those multiple factors. So I think it's kind of being very cautious and being thoughtful about when using stimulant medications, but also not being afraid to manage ADHD appropriately, as that can really interfere if it's not well managed in terms of academics as well as behavior therapy.
Great, thank you. Next question. Can you speak to the relationship between trauma and tics? Is there evidence of an increase of tic expression due to exposure to trauma-related reminders or triggers?
I mean, so one great question. So let me separate this out. One, does trauma cause tics? There's no evidence that traumatic events can cause tics at this time. No good empirical evidence. That being said, for somebody who does have tics, if we think about traumas, stressors, or anything that affects anxiety and our fear responses, anytime those things are present, anytime we're reminded of them, we're going to have greater tic expression, because we know stress makes tics worse, anxiety makes tics worse. So seeing reminders of trauma and trauma-related triggers can also increase tic expression. Now, going back to that functional-based intervention of CBIT, we still would want to try to, manage and kind of help people kind of work through and build resilience around that by using the skills that we know are successful to kind of effectively cope. But really great question.
This goes back to one of the questions you answered earlier about the resources. Can you just repeat the resource where parents can go online and look for therapists?
It would be www.tourette.org, and there's like a find a provider link there. Yeah, thank you. Yeah. And if you click on that kind of page, you'll see the find a provider.
And we
Uh,
can send that out afterwards as well, so you guys have.
And hopefully this will be one of many presentations or one of ways we can also kind of connect with you guys to figure out how we can kind of provide tools and resources to make referrals easier and to help patients kind of get into care, because it's a big priority.
We have another question. How long should we wait before referring them to behavior therapy?
So what I would say, how long should you wait? I would say refer them once you kind of identify somebody who has tics. I think it's a great opportunity to kind of connect them to the Tourette Syndrome Center of Excellence here. So that, we even providing psychoeducation about kind of the condition, so parents kind of know, so parents feel less scared and kind of know a little bit more about the trajectory of the kind of condition, as well as then we can start to kind of monitor and when to kind of provide care and start to implement that. Because if you start it too early, going to the doctor, seeing me is always a pain, as you guys have heard, like me talking for like 40-50 minutes, it's rough. I put many kids to sleep. So you don't want to start that too early, but really thinking about when to kind of do that's important. So I'd say connect them to us and we can kind of take it from there.
Okay, next question. Any recommendations on how long CBIT should take place on average duration for moderate cases?
So I think it depends on a couple of things. So see, I think one, it kind of depends on the individual's kind of awareness of tics. Right, going back, you can't stop something unless you're first aware of it. So if somebody has pretty low awareness, it's going to take a little bit longer than they have kind of greater awareness. If somebody has, inattention, hyperactivity, and impulsivity, that's also going to make kind of treatment a little bit harder. Or if they're not practicing in between therapy visits, it's going to take a little bit longer. So going back to that kind of standard course of treatment, it was 8 sessions over a period of 10 weeks, and those first 2 sessions were 90 minutes. So really, if you think about 10 hours of therapy over 10 weeks, what people would consider to be an average dose of kind of CBIP. But in practice, there's much more variability because there may be more tics that are there, and also comorbid challenges may come up in the interim. Somebody may also kind of have OCD and ADHD as well as anxiety, which can kind of prolong the course of a patient's care. So while CBIP may only be 10 or 12 sessions, for those moderate cases, it could actually be, an overall patient's journey might be much longer.
Thank you. Another question, can you recommend any resources for more information on competing response training?
So the two resources that are probably the best for identifying kind of competing responses in behavior therapy are the CBIP manual that I put up there. And then also there's a chapter in one of those edited books that I did with Elsevier that was written by Emily Ricketts, and the book's called The Clinician's Guide to the Comprehensive Treatment of Tourette Syndrome. I do get a quarter or something like that every time somebody buys one, but if you need the table, happy to kind of send that to you specifically. It's a really nice resource that provides a lot of information to help build resilience and provide patients with therapeutic skills that are known to be efficacious and effective for Tourette syndrome. It gives you a table of how to kind of do it and also how to think through different strategies for competing responses.
Great, thank you. And again, all the resources that were in the presentation we'll be sending to you afterwards. So you'll have those. Any other questions?
Comments or personal feelings, all 3 are welcome.
We'll give it another minute or so.
And hopefully this, again, will try to push some stuff out to increase kind of connections with primary care providers. Because I really, one of the things that's, we know we can alter the trajectory of young people who have this condition and really support them into adulthood. So why not try to kind of do it sooner, rather than later, and really try to remove the barriers to do so. And you guys are a huge part of that. So thank you for coming and thank you for listening.
And thank you again, Dr. McGuire, for a wonderful presentation. So the recording for today's session, the slides, and a list of related resources will be available on our website next week. And we'll also send those out via email. We will send CME and CU certificates to participants by March 5th. Please remember to take the evaluation survey as you exit, as it's required if you'd like to receive CME or CU certificate. It was placed in the chat, and we will also send it to you via email. And stay tuned for future BHIPP trainings by following us on LinkedIn, Facebook, or Twitter. And thank you again, everyone, and I hope you all have a great rest of your day. Thought there was another question, but we're good.
No, that was a wonderful, they commented on that was a wonderful presentation.
Yeah, okay. Just want to check one more time, and I think we are good.